All right, I'm going to talk about hormonal cycles in the female reproduction system. The first lecture was in talking about contraception. Now we're going to talk about the whole point of trying to rearrange your hormonal cycles with contraception. And we're going to learn about the anatomy and physiology of what happens for ovulation and getting ready for pregnancy. So within that, we have to learn a little bit more about the ovaries and the hormonal cycles that affect the ovaries. And then finally, we'll get into, a couple pathologies about the uterus and the ovaries. True or false? Men can keep producing sperm, but women are born with only a limited number of oocytes or eggs. And that's true. Men can keep going on producing sperm until they die. Women have very limited number of eggs. We're born with about 1 million eggs, and then we slowly start losing them for multiple different reasons. And at puberty, when we can start ovulating, we only have 300,000 left. And only 300 to 400 will be ovulated during a woman's lifetime, reproductive lifetime. So the ovary is your egg storage facility, and they all are there as potential. They're not ready to go when you're born, but they have to be prepared and then released. And the primordial follicles are the things you have at birth, the 1 million that you have at birth. And then for whatever reason, some of these don't grow, they dissolve, but 300,000 roughly are prepared to take off to be part of the ovulation process. So since you have so many primordial follicles, why don't human females have litters of children like dogs have litters of puppies? Is it because human sperm are not as active? They're not being fertilized? Or is it because the ovary usually doesn't allow more than 1 egg to be released? And the truth is, the ovary does not allow usually more than 1 egg to be released. So during follicular development, as one reaches maturity, it releases a hormone or a chemical called inhibin that inhibits other follicles from further development. So they quit maturing essentially. And this is a depiction of a cross-section of an ovary with a developing follicle, developing to an ovum, reaching maturity. And around in here is when they release the inhibin. Once they get to this stage, that one particular follicle will release inhibin. And then breaking through the ovary to be released and hopefully fertilized. So how about this medical scenario? Your 17-year-old sister frequently complains of pelvic pain around mid-cycle, which is day 14 of the menstrual cycle. And she has severe cramps and heavy menstrual periods, all of that. So to treat her, her doctor places her on birth control pills. So he's using the birth control pills for menstrual pain, heavy bleeding, and that mid-cycle pain. Is that a good treatment option? And the answer is yeah, it's a great option. Birth control pills prevent ovum from being released, so you stop that mid-cycle pain. And also, since it stops this ovulation process, it slows down, that was my dog, by the way. It slows down that endometrial development, lining. You don't have to shed so much endometrium, so the cramps are better during the menstrual cycle. And that mid-cycle pain is called Mittelschmerz. Comes from middle and pain, the German word Mittelschmerz. And that's during the time that the follicle is releasing the ovum. And the birth control pills, as you remember from the last presentation, birth control pills prevent ovulation so you don't get that pain. So the first step, the ovum develops here, and it's surrounded by these supportive follicular cells. Step 2 is the actual ovulatory process where the ovum is released. And step 3 is this corpus luteum. Luteum means white, so it's a white body. It is actually secretory. It secretes progesterone and it supports the lining of the uterus. So this is why the ovary secretes both estrogen and progesterone. So LH and FSH, as you remember, are released by the anterior pituitary gland. FSH, or follicle stimulating hormone, starts the follicle's development. So what does luteinizing hormone do, LH? Does it support the endometrial lining or release the ovum? And it releases the ovum. And the way to remember LH is it's the letter fly hormone. And this is a chart of the days. So mid-cycle, you get this surge of LH in the pink line here, this big surge of luteinizing hormone, and that breaks that ovum free. And left behind is this corpus luteum, this white body here. And notice it's during this time of this breaking through that there actually is bleeding. And so you can get a cyst, actually, a bloody fluid-filled cyst within the corpus luteum. So you could see that potentially on ultrasound. And some are bigger than others. So all this time, the uterus is being prepared for implantation of a embryo, a fertilized egg. So looking at the beginning of the month, the menstrual cycle, the menstrual phase is the sloughing of that uterine lining. And then it goes to this proliferative phase where the lining starts growing, hoping that there's going to be an implanted embryo. At ovulation, the endometrial lining starts into its secretory phase. And that is being initiated by that corpus luteum, secreting progesterone. And the secretory means that it's secreting food products to support the embryo, because at this point, obviously, there's no placenta. Okay. So, quiz question. From what I've told you, what does the corpus luteum provide? Thicken the endometrium or sustain a pregnancy? And the answer, it does both. Makes the endometrial lining thick and then starts secreting chemicals to support the uterus, support the baby, the growing baby. So there's no placenta yet. Progesterone maintains the endometrium. Endometrium feeds the growing fetus. So in the secretory phase within there, imagine it like a big baby bottle full of lipids, glycogen, and proteins. So food for this growing embryo. All right. So let's go on to the menstrual phase. What happens when there's no implantation? And this is just a little cartoon off the internet. It's your uterus holding an egg saying, I made you a thing. I produced an egg. You don't want it. Took me days. And now you suffer. And for those of you that get some menstrual cramps, you can relate to this. I can relate to this. At day 28, if there's no implantation, if there's no embryo, no implantation, the endometrial lining sloughs. Okay. Now, quick quiz, how we've gone so far. Name the 2 ovarian hormones that prepares the uterine lining for a fetus. Is it estrogen and progesterone, or progesterone and luteinizing hormones? Now, this is a trick question. I'm asking you the hormones from the ovary. So the answer is, that is so wrong, Judy. The answer really is estrogen and progesterone. Remember, luteinizing hormone is coming from the anterior pituitary. So this little red circle needs to move up to encircle estrogen and progesterone. So progesterone from the corpus luteum and estrogen from the ovary. So the female hormone chain of command goes gonadotropin releasing hormone from the hypothalamus, luteinizing hormone and FSH from the pituitary. The ovaries release estrogen and progesterone, impact the uterus, and hopefully they're hoping to provide a fetus or a newborn baby at the end of all this. That's the whole goal, is reproduction, propagation of the species. So let's go into another scenario just to solidify what you've learned. Your cousin has been trying to get pregnant and finally misses her period and has a positive pregnancy test. A week later, she complains of one-sided pelvic pain and goes to the ER. They see a 3-centimeter cyst on her ovary with the ultrasound. So, should her cyst be removed to relieve her pain? Yes or no? And the answer is no. That's a corpus luteal cyst that it will keep the lining, keep the embryo supported until a placenta grows. So if you remove that cyst, most likely you'll lose the pregnancy. So this is called a follicle cyst or a functional. It's got a function. It's formed at ovulation. It's common to see it during menses. It can get real painful if it's large because it pulls on those stretch receptors. It's going to be there in early pregnancy and should not be removed if the pregnancy is wanted. And that's what's happening in the ovary with the luteinizing hormone, the corpus luteum here filling with blood. So if one bleeds a little more at one time, it can create a much bigger cyst, a fluid-filled cyst. So what hormone is being tested in the ovulation kit? Is it FSH, LH, or progesterone? The answer is LH, luteinizing hormone. So it used to be that women would take their body temperature because at the time of ovulation, you'll get this spike in temperature. So they would have women do basal body temperature charts prior to the commercial availability of checking luteinizing hormone. Let's go on to pathologies of the uterus, ovaries, and cervix. So cervical cancer, there's multiple risk factors. In general, or my husband, who's an OBGYN, would say 100% of the time, this is caused by the herpes simplex virus, or excuse me, human papilloma virus. Oh my gosh, I just misspoke. He would kill me. So the human papilloma virus is a sexually transmitted disease. And this is the different stages of cancer. This will come with multiple sexual partners, sexual intercourse starting in an early age, getting HPV, and also having a weakened immune system. And all of this can increase your risk of developing cervical cancer. This is what it looks like. Now with the Pap test, they're scraping just a few of these cells because it's not always obvious that there's some abnormal cells on the cervical os. So the Pap test, they just use a little scraper, a speculum, go in and just grab some cells from the cervix and put them on a little plate and send it to pathology to look for any abnormal cells. And the recommendation is screening starting at age 21 to 29 and having that done every 3 years. And then usually the recommendation is stopping after age 65 if person's had a normal Pap for 10 years. Simply because if everything is normal, the risk of getting cervical cancer beyond age 65 and having normal Pap smears is pretty low. So HPV, human papillomavirus, is the #1 cause of cervical cancer in the world. And that is what's being affected by the HPV virus. This is showing an image. The vagina is taken away, and this is just the opening showing here of the uterus, the cervix. Okay, another pathology is called a dermoid cyst. And this is an ovarian tumor. It is not a malignant tumor. And this image here is showing laparoscopy for this pelvic tumor. So they've blown up blown inside the peritoneal cavity with CO2. So you can see these structures, and this is what the OBGYN would be looking at, looking down, and this is what the camera would see: the uterus, a normal ovary on the right, and then a dermoid cyst. So it's a big cyst growing on the left ovary. And it's developing from one of these oocytes. It hasn't been released. It's not fertilized, so there's only 23 chromosomes. But even with those few chromosomes, it can grow all kinds of tissue. It can grow hair, teeth, bone. It can grow all of those things. And of course, it's going to be most common during the childbearing years. So here's an image of the dermoid, and you can see teeth, you can see hair, all of those things. That's the cyst. And again, this is not an embryo. This is a 23 chromosome cyst. These structures have grown out. So this is a retained primary oocyte that didn't get released. Okay, next thing, let's talk about uterine fibroids. The medical name for that is leiomyomata. And they can happen anywhere around the uterus. They're non-cancerous. The only problem is that they can actually make it difficult to get pregnant, can cause persistent bleeding during menstrual periods. It could be any of these locations or types of fibroids. A big reason for having a hysterectomy as well later on, after the childbearing years. And sometimes they can just do a removal of a fibroid so a patient can still keep their uterus and go on and get pregnant. And they can get very big. This is a picture of a uterus with lots of fibroids, and here's this big pedunculated fibroid on the end of the uterus. All right, next is endometriosis. This is like, I guess you could call it metastatic endometrium. So it's endometrial cells that are growing outside the normal placement. They're not exactly sure what causes it. Some people think it might be retrograde flow, like instead of the menstrual fluid and the endometrium sloughing off and coming out the vagina, perhaps they're thinking some of it might be retrograde flow going through the fallopian tubes. So you'll get these attachments of endometrium, all places on the bowel, on the ovaries, and these can be actually very painful, especially during the menstrual cycles. And some of the complications from endometriosis, from these abnormal implants, can cause inflammation, and then it can start with this adhesions. And remember when we talked about adhesions in the GI tract? These adhesions are fibrous bands that cause pain. And so a laparoscopy exam and then taking down these adhesions in surgery laparoscopically helps. And then also they can directly burn those or cauterize those implanted pieces of endometrium. So this is what it looks like, through a laparoscope. This is what the GYN would see, these bits of endometrium. So there's a lot of other options. You can take out the ovaries, you can suppress ovulation, and you can surgically remove or cauterize those. And then you can suppress the continuous hormonal swings with estrogen or continuous progesterone. So this is a cadaver specimen, just to have you look down what you'd be seeing in the pelvis. This is the uterus, fallopian tubes, and then of course, the ovaries. Notice this is these ovarian ligaments and fallopian tubes. You can see how they'd be very easily mistook for one or the other. This is a sagittal view as well, showing the vagina, the cervix, the uterus, and of course the rectum. So in summary, the ovaries are there to support a pregnancy, to get a pregnancy going. The uterus is for the embryo. It supplies the food source. It provides the space. The hormonal cycles keep going over and over again, roughly every 28 days. Then we talk about some of the pathologies: endometriosis, dermoids, fibroids, and cervical cancer. And then the cycles, again, the cycles: ovulation, mid-cycle, corpus luteal development at the end of the cycle. And then here's the sloughing of the endometrial lining of the uterus, and then preparation in hopes for an implantation of an embryo the next time. So this is the proliferative phase where the endometrial lining is growing, and the secretory phase is where it's secreting food substances for embryo.